Hemoglobinopathies. Question. A healthy 2-week-old female has an abnormal newborn hemoglobin screen pattern of FS. You discuss the finding and implications with the family, examine the child, and obtain a complete blood count and hemoglobin electrophoresis. Which of the following is your next best steps? A. Test the parents for thalassemia major. B. Avoid giving vaccines at 2 months of age. C. Contact the pediatric hematologist and start penicillin prophylaxis. D. Transfuse packed red blood cells. Or E. Obtain a gallbladder ultrasound. The correct answer is C. Contact a pediatric hematologist and start penicillin prophylaxis. The infant in this story has a newborn screen consistent with sickle cell disease, an inherited hemolytic anemia due to a beta-globin gene mutation converting hemoglobin A to hemoglobin S. While waiting confirmation with a CBC and hemoglobin electrophoresis, it is important to establish care with a specialist and prevent fatal infections due to Streptococcus pneumococcus by starting penicillin prophylaxis. Answer A is incorrect. Testing the parents for thalassemia major does not currently help this child with suspected sickle cell disease. Answer B is incorrect. Avoid giving immunization at 2 months of age puts this child at risk for fatal infections. Answer D is incorrect. Transfused red blood cells is not a standard treatment for stable infants with sickle cell disease. And answer E is incorrect. Obtaining a gallbladder ultrasound is not indicated in an asymptomatic child with sickle cell disease. Let's just go back a little bit to what a normal hemoglobin is. As we leave the womb and are born into this world, we develop a lot of adult hemoglobin or hemoglobin A. Hemoglobin A is consisted of 2 alpha globin chains and 2 beta globin chains, as noticed here. And they surround the heme molecule, which is literally an iron molecule attached to our carboxy hydrogen nitrogen molecule called the heme molecule. And iron will attach to this heme and be released to this. So we need all of this for a stable hemoglobin A. And just a brief summary here. This is a chart of total hemoglobin made by the globin chains at various points of a person's life, including from conception to birth, this line in the middle, to the first several months of life. And as you can see, prior to birth, there's a lot of alpha globin chains and gamma globin chains, and 2 alpha and 2 gamma chains are consistent with fetal hemoglobin or hemoglobin F, whereas after birth, if there are no mutations, a person will make more beta globin chains and less gamma globin chains, and they'll have more hemoglobin A, which are 2 alpha and 2 beta chains, and may have a little bit of hemoglobin A2, 2 alpha and 2 delta chains. Please remember that delta chains aren't made until around birth. So when a person is born here in the United States, there's mandatory newborn screening and includes many metabolic disorders, including the hemoglobinopathies. And the reason why this slide contains a few of the responses or answers on the hemoglobinopathy panel is to be aware and not to confuse them. Hemoglobins on the newborn screen are reported in the order of abundance. The first letter, F, fetal hemoglobin, makes sense. You're just at birth, you have more fetal hemoglobin. And then the second one, less prominent at birth, will be the next most prominent hemoglobin that you make. And for a newborn, a normal newborn, FA is standard. If you see FS, this is indicative of either hemoglobin SS or hemoglobin S beta 0 thalassemia. This is sickle cell disease, and this requires referral to a hematologist. If you see FAS, that means there's hemoglobin F, there's some adult fetal hemoglobin, more than there is hemoglobin S. This is called sickle cell trait. Again, this is just a newborn screen. We still recommend confirmatory testing with hemoglobin electrophoresis, even for sickle cell trait, and we recommend some guidance from a hematologist. As you may be aware, those with sickle cell trait are very healthy. However, it's important to know about for several reasons. In childhood, there is decreased concentration of the urine, and in settings of dehydration, there's an extreme exercise, there's a high risk of rhabdomyolysis, a very severe condition where there's muscle breakdown. The family needs to be aware of this. As the child ages and becomes an adult, there's increased risk of thrombosis, especially in settings of hypoxia, such as high altitude, smoking, dehydration, and there's also an increased risk as an adult of kidney disease, as well as a special cancer called renal cell carcinoma, which has a higher increased risk in those with sickle cell trait than in the general population. We also like to give counseling to the family. If a child has sickle cell trait, we like the parents to be checked, because if they're going to have other children, they may be at risk for having a child with sickle cell disease. And then the person with sickle cell trait, as in this child, would need to be counseled and their reproductive partner tested for hemoglobinopathy to see what their risk of their children having sickle cell disease as well. What's often confusing, or we get a lot of questions about, is a hemoglobin electrophoresis, a newborn screen pattern of FSC. This is indicative of hemoglobin SC, or sickle cell C disease. This is a sickle cell disease as well, although it is typically milder than sickle cell disease caused by as seen in SS or S beta 0 thalassemia. This still requires confirmatory testing with hemoglobin electrophoresis and referral to the hematologist, because this is sickle cell disease. A pattern of FSA, where the S is before the A, is indicative of hemoglobin S beta plus thalassemia. This is also sickle cell disease, although it is more mild compared to hemoglobin S beta 0 thalassemia. This is still sickle cell disease, which we'll talk about, a very complicated, severe condition. I wanted to mention that sometimes the newborn screen will mention FX or other, quote unquote. This indicates that there's a hemoglobin variant, and it is unclear whether that variant will be homozygous or heterozygous as a trait. So confirmatory testing with hemoglobin electrophoresis is important. If you see F followed by fast moving or hemoglobin Bart's, this is indicative of alpha globin gene mutation, and that requires referral to hematologist as well. And if you only see F on the hemoglobin screen, that is indicative of beta thalassemia major, meaning you can't make hemoglobin A, or even a mutated variant of hemoglobin A, such as hemoglobin S or D or E, or a variant. And those who have a newborn screen of F will most likely require chronic transfusions because they have beta thalassemia major. So again, always important when you get these screens back. If you have any questions, always review with the hematologist. They are not confirmatory, they're a screen, so please get a hemoglobin electrophoresis. And as you know, the hemoglobin electrophoresis is reported as percentages, so you'll know the varying amounts. It is more quantitative than qualitative. So common hemoglobinopathies, Sickle cell disease I mentioned already, which we'll discuss. There are alpha or beta thalassemias and various hemoglobin variants. Features of hemoglobinopathies: there will always be an abnormal newborn screen, always ask about family history. There typically will be anemia. It can be mild anemia, where the person is healthy and sometimes the red blood cell count or hemoglobin is on the low end of normal. Or it might be quite severe, where they're actually transfusion dependent at birth. Different types of hemoglobinopathies have different complications. The diagnosis of the hemoglobinopathy depends on your history and physical, your CBC retic count, your smear. All of them will be DAT negative. You'll get a hemoglobin electrophoresis, and of course, please get the family history. That is very important. So, a little bit about sickle cell disease. And the reason why I put this is because you'll get a hemoglobin electrophoresis, and you'll say, now what do I do with the results? So typically, those with more severe sickle cell disease, as in SS or S-beta thal, their hemoglobin will show severe anemia, a standard chronically, born like this. That's how it is. And typically, their hemoglobin S will be very high, 80-90%. They will have no hemoglobin A. In hemoglobin SS, the A2 will be normal or low. In S-beta 0 thalassemia, the A2 will be high, ergo the beta thalassemia. The hemoglobin F may be present in varying amounts, and there's no hemoglobin C. Please note that in hemoglobin beta plus thalassemia and hemoglobin SC disease, both sickle cell anemias, their hemoglobin levels chronically are more, signify a more mild anemia, or maybe no anemia. They will have a high retic count, that is true, but they might not even be anemic. Their hemoglobin electrophoresis will definitely show a hemoglobin S of 50% or higher. In sickle cell trait, please remember that the hemoglobin S will be less than 50%. Sickle cell disease, it'll be more than 50%. In this hemoglobin S beta plus thalassemia, the hemoglobin A there'll be some present, and there'll be an elevated A2. Whereas in hemoglobin SC disease, there'll be no hemoglobin A, but there will be presence of hemoglobin C. And that's how to differentiate these. Hemoglobin SC is not sickle cell trait. It's hemoglobin SC disease, a sickle cell disease. So we've talked about sickle disease. What do we need to know about it? Please remember that it's an autosomal recessive mutation in the beta globin chain gene. Increased incident in African Americans, yet it is seen worldwide. In Germany, in South America, you will see sickle cell disease. And what's so important about knowing about this in the newborn period is that we can prevent severe infections, which used to be devastating, and the current life expectancy in people with sickle cell disease approaches 60, 70 years of age, whereas 30 years ago it approached 20 years of age. It can affect the whole body, and what happens is these red blood cells that are mutated are and the hemoglobin gene that's mutated creates a red blood cell that is mal-shaped. And these red blood cells will cause inflammation along the blood vessel wall as they float by, activating selectin molecules along the red blood cell walls and causing clotting. And when you clot off various blood vessels in your body, you'll have pain, decreased oxygen there, and the decreased oxygen in that area will cause you to make the red blood cells sickle more or turn into an odd shape even more and become more adhesive, more adherent, causing more problems. And the clinical emergencies that can happen due to this veno-occlusive diseases include acute chest syndrome, splenic sequestration, aplastic crises, strokes, priapism, as well as what we used to call pain crises or vaso-occlusive crises. And it can happen all over the body. So an emergency in sickle cell disease is fever. So anybody who presents to your emergency room with fever should get a complete workup with a CBC, erythrocyte count, and a blood culture. And IV antibiotics should be started right away. In fact, it's a good quality of measure of your institution in terms of getting antibiotics to your patient as rapidly as possible. In children less than 18 months of age, we recommend admission. Not all people with sickle cell disease and fever need admission, but most do. And why do they need admission? Well, they're immunocompromised. Their spleen is not effective. Your sickle cell disease, the spleen often auto-infarcts within the first year of life. And you are susceptible to encapsulated organisms. Besides strep pneumonia, you're also at risk for meningitis and Haemophilus influenza. So we start penicillin prophylaxis within the first month or two of life, 125 milligrams orally BID. We also encourage the pneumococcal vaccines, and since the advent of giving the pneumococcal vaccine at 2, 4, and 6 months of age, we believe this has improved overall survival. Vaso-occlusive crises present acutely. They can be triggered by changes in temperature, dehydration, hypoxia. So it's very important to counsel families on maintaining hydration, wearing appropriate clothing, and avoiding extreme heats or cold. So not jumping into, on a hot summer day, not jumping into a cold pool or standing in front of an ice cold air conditioner, because these scenarios will set off a pain crisis or a vaso-occlusive crisis. The pain may occur anywhere in the body. You won't necessarily see swelling or erythema. And most children with sickle cell disease will have a pain control program in place at home, where they, in low, in settings where their pain is less severe, they will know to take acetaminophen or ibuprofen. In moderate severity, they may take those two medications as well as a low-dose narcotic. And in severe pain, we recommend that despite doing those other things at home, they come into the hospital for other interventions. And when they do come into the hospital, we try to start fluids as rapidly as possible, but not overhydrating them, which could lead to acute chest syndrome, and not over doing with the pain control where they would have difficulty breathing. There are many medications now that we offer to families within the first couple of months of life. We offer hydroxyurea to raise hemoglobin F levels. It has been shown to decrease the number of episodes of pain crises, to some people to 0, others to 1 or 2 times a year, versus coming into the hospital 10 to 20 times a year. It also has been shown to decrease the incidence of acute chest syndrome. Acute chest syndrome is defined as chest pain, infiltrate on the chest x-ray, and hypoxia. And when a person comes into the emergency room with this, it is a medical emergency where we set up an IV, we give antibiotics right away, we cover for mycoplasma as well as strep pneumonia. We give pain control through IV oral anti-inflammatory drug, as well as narcotics. We provide oxygen or other respiratory support, and sometimes we have to do an emergent transfusion, and in very rare cases, an exchange transfusion. so that we can prevent severe respiratory distress and decompensation. Those children who have had acute chest syndrome once are at more risk of having it a second time. Splenic sequestration may occur in those mostly before the age of 2, because after the age of 1 or 2, the spleen autoinfarcts. This scenario is an emergency as well, where the spleen decides to not only accumulate all the red blood cells in the body, but sometimes the white blood cells and platelets. The spleen enlarges. Presentation includes tachypnea, tachycardia, hypotension, and the spleen may go all the way down to the pelvic area and cause the abdomen to be quite firm. You might not even be able to feel the normal abdomen in there. Children complain of abdominal pain or may have vomiting. Emergent transfusion is necessary. Hydration, support, cardiovascular support, as well as pain control. Aplastic crisis usually occurs less rapidly. It's usually due to parvovirus, but other infections can occur as well. Can cause this as well. The anemia that occurs with this is due to the bone marrow not making red blood cells, so the reticulocyte count is low or close to 0, and yet the person still has sickle cell disease, so they're still hemolyzing their red blood cells, and often a transfusion is necessary to get them through this. The infection causing the aplastic crisis may resolve within days to weeks. A stroke or a cardiovascular accident used to be quite common in sickle cell disease. We now screen all children regularly with a transcranial Doppler ultrasound to assess their risk of stroke. It's a mandatory screening. If any of your patients have not undergone it, please encourage them to do so. If we do find that there's decreased flow through their blood vessels leading to their brain, we recommend chronic transfusions every 4 to 8 weeks to keep the hemoglobin S below 50%. This has decreased the incidence of stroke. Hydroxyurea may also help with that. Although we do this screening, some people still present with stroke, and that is alarming because you think, the headache, that is just from a pain crisis. But please do a full neurological exam and see if there's any neurologic dysfunction. Ask about seizures. This is an emergent situation. We either will give a transfusion or an exchange transfusion right away in an ICU setting to prevent further damage to the brain. Children do have rehabilitation, physical therapy, occupational therapy, speech therapy afterwards, and can do well. To prevent recurrent stroke, which happens in up to 40% of people who've had their first stroke, we give chronic transfusions, red blood cell transfusions. Gallstones are also a complication of sickle cell disease, often found in teens or young adults, presenting with right upper quadrant pain, fever, vomiting, and are discovered on ultrasound. And the treatment for this is cholecystectomy. Priapism is where there is a vaso-occlusive crisis in the penis. This can, in the short term, it can self-resolve. In the long term, it can cause significant scarring to the young men. So we recommend management with fluids and pain, and we contact urology. We sometimes will give a simple red blood cell transfusion, or a person may need exchange transfusion. And we often give Sudafed as control therapy. Hydroxyurea has also decreased the incidence of priapism. Preventative care. We all recommend all of the vaccinations, penicillin prophylaxis throughout childhood, but it often is stopped around 5 years of age. Hydroxyurea, families will often ask if that's an option. We are now saying that this is one of the mandatory meds for sickle cell disease to decrease your symptoms. If there are significant side effects to hydroxyurea that a patient experiences, then we will discontinue it. I've already mentioned transcranial Doppler ultrasound imaging, and we have a protocol for this. For those who have had a stroke or acute chest syndrome or have had multiple transfusions or very severe sickle cell disease, we do offer stem cell transplant and gene therapy. These are curative therapies, but do come with their own side effects. And as I mentioned before, we try to avoid rapid changes in temperature as well as dehydration. And we recommend a healthy lifestyle, healthy diet, exercise, and pain management through cognitive behavior therapy, dialectical behavior therapy, group support, imagery, as well as physical therapy. Sometimes we'll recommend magnesium and other interventions. Thalassemias. Thalassemias result from genetic mutations in either the alpha, beta, gamma, or delta globin genes. And it's typically an imbalance when you have a mutation in any of these globin chains, and therefore there's an abnormal rate of globin synthesis and ineffective erythropoiesis, meaning the red cells are fragile and they don't last 120 days like a normal red blood cell does, and they'll break apart and you'll result in anemia. A child with chronic thalassemia, if it's major, will have signs of marrow expansion, meaning the bone marrow is trying to make a lot of red blood cells. Those red blood cells are short-lived, but the marrow just keeps trying to keep the red blood cell count to normal. And so often you'll see enlarged forehead. The maxilla will also be large, and because the bone marrow is packed, there is thinning of the bones over time. And a person with chronic thalassemia will have anemia, an enlarged spleen. The spleen recognizes that the red cells are fragile and it'll try to clear them out of the bloodstream. The liver serves as an area of hematopoiesis because the bone marrow is maxed out and the liver tries to help. Jaundice is common, scleroicterus is common. This is the elevated indirect bilirubinemia. These children are transfusion dependent, so they will develop iron overload, and they will typically be short in stature. In the case of alpha thalassemia, the cause is usually due to a decreased production of the alpha globin chains. Either you're missing one or more of the 4 alpha globin genes. If you're missing all 4, you will present with hemoglobin Bart disease or hydrops fetalis, meaning in the womb you cannot make alpha globin genes at all. You become severely anemic, and to survive this you would need transfusions in utero. If you are missing 3 of the 4, you will develop hemoglobin H disease or hemolytic anemia. The severity varies from mild to severe, where mild is you're anemic with a high retic count but don't need any transfusions, to severe where you might need transfusions several times a year. Alpha thalassemia trait, it results from 2 globin genes being mutated out of the 4. This results in a microcytic anemia Or sometimes the red blood cell count may be in the normal range as well. The hemoglobin may be in the normal range as well. Alpha thalassemia silent carrier is microcytosis only, no anemia. That's where there is missing one globin gene out of the 4. This is commonly found in people of Southeastern Asian descent, Mediterranean, Middle Eastern, or African ancestry. But we are all a mixing pot, so and many people don't know their ancestry, so do not limit it to the people that you think have this ancestry. Diagnosis is made by history and physical and family history. You get the CBC, you get your blood indices, your retic count. Hemoglobin electrophoresis will be normal, except in hemoglobin H disease, where you will see the hemoglobin parts. It's important to test the parents. And DNA analysis can be used. I'm going to talk about that in a minute. Treatment includes education, meaning it's important to know about this so that the person's future reproductive partner would be tested to see if they have this, because of the risks of their children having a more severe anemia. Also, we ask that the parents be tested if they're thinking have other children in the future for their risk of having other children with more severe anemia. Blood transfusions for those who need the support, folic acid for those with hemolytic anemia due to hemoglobin H disease, and splenectomy is sometimes indicated in hemoglobin H disease. So let's go back just to the details of the diagnosis. So on the newborn screen with alpha thalassemia, you're going to see hemoglobin Bart's or hemoglobin FAB, or a fast-moving hemoglobin. This is supportive of alpha thalassemia trait, but does not diagnose this. So we confirm our testing, you would think with hemoglobin electrophoresis, but hemoglobin electrophoresis in alpha thalassemia trait is normal, so you'd want to get the alpha globin gene analysis. It is very expensive. So you would make sure there's no iron deficiency. You would probably get a hemoglobin electrophoresis, make sure there's no beta thalassemia trait before getting the alpha globin gene sequencing, or just contact your hematologist. The diagnosis of hemoglobin H disease on newborn screening shows the hemoglobin Bart's, and that is supportive. And you'd want to confirm this with the hemoglobin electrophoresis, because you will see the hemoglobin H on it, and we will sometimes get genetic testing. Our hemoglobin electrophoresis can pick this up, some don't, so genetic testing might be helpful. Again, hemoglobin H disease is where there's anemia with an elevated retic count or a hemolytic anemia. These children are susceptible to oxidative stressors, similar to those with glucose 6-phosphate dehydrogenase deficiency. So you'll want to avoid those kind of chemicals or medications. Beta thalassemia, a little bit different, although similar. There's an unstable hemoglobin from the decreased production of beta globin chains, and you're missing one or two of the beta globin genes. Beta thalassemia major is due to a mutation in both alleles, and there's severe hemolytic anemia and extramedullary erythropoiesis, whereas beta thalassemia minor or trait is a defect in only one allele, and you'll have a microcytic anemia. And the diagnosis is made with history and physical, as well as family history, CBC, the red cell indices, the retic count, hemoglobin electrophoresis, and you might have to test the families or do a DNA analysis if inconclusive. And treatment in severe beta thalassemia major are blood transfusions chronically. You'll have to give iron chelation, folic acid. Splenectomy is sometimes indicated, and we are offering stem cell transplant as well as gene therapy for this condition as well. For beta thalassemia trait, there's no intervention necessary. These are healthy individuals. How do we come about the diagnosis of the beta thalassemias? Well, for the trait, you'll have a normal newborn screen, and that's supportive of this condition. So you won't know they have beta thal trait until you screen them for your iron deficiency or otherwise. and you'll see that they're mildly anemic. And you may, by mistake, give them iron, thinking that you have iron deficiency in that child. And when their iron levels come back normal and their hemoglobin is still low, you'll get a hemoglobin electrophoresis. Please get the hemoglobin electrophoresis when the iron levels are normal. A low iron level will cause low production of hemoglobin A2, and you'll miss the diagnosis of beta thalassemia trait. In beta thalassemia trait on the hemoglobin electrophoresis, you'll have an increased level of hemoglobin A2, and that'll be the definition. The diagnosis of beta thalassemia major is a little bit more clear-cut. On the newborn screen, you'll just have hemoglobin F. The baby will be quite anemic, a little jaundiced, and your hemoglobin electrophoresis will confirm this, as well as genetic testing. And unfortunately, the baby will need transfusions. That is the end of this slideshow. Thank you for joining me, and I look forward to seeing you in the next. Thank you. Bye-bye.